Okay, so the question to you for people who are not able to join and want to go back to this recording, we're talking about what would be the impact if dementia cases increase by 2050 or 2025. It will be 2050, by the way, to families, health system, and economy. Rani?
Yes. So, if the dementia rate increased by 200% in Lebanon over the next 25 years, we thought it would increase the burden on the caregivers. It would also cause emotional stress and burnout due to the long-term care that a patient with dementia would require. It would also cause some kind of financial strain on the family members due to the cost of the medications, due to the cost of the care services, and sometimes the caregiver might leave the job to take care of the patient. So, and that might lead to the loss of income. Uh, and it also leads to a change in the family structure because elderly patients require like constant supervision.
Okay, so we're talking about caregiving, stress, finances. Ya Allah. Sorry, don't know what happens. I'm sorry. Okay, so you see again my screen, right?
Yes.
Just notify me when something.
Yes.
Yeah, okay. So the question is caregiving, stress, and finances. Why is caregiving would be a particular burden, more a burden, I mean, in the future? Can I hear from Rima or someone else? Thank you, Rani.
Yes, hi, doctor.
Yeah, hi. Are we still
Uh,
recording? Yes, okay.
yes. So caregiving is supposed to be of high burden in the future due to the like the aging population and the like the huge number of people who are expected to be diagnosed with dementia.
Okay. To anyone else, so on whom would the caregiving fall in 25 years? Any thoughts? With the
Maybe
change in demography.
on the
the
children.
Yes,
the
Mariam.
children, yeah, and also the partners, their spouses.
Okay, so children not much, but I mean more and more the caregiving would fall on the people who are, you know, the older people would assume more caregiving of older people because population are aging, right? At least we're talking about Lebanon demography. We have much smaller fertility. People are migrating. Young people are not able to care for their older. So what happens is that it's like a dual challenge on older people. So we have more people in need of caregiving, but the caregiving not only fall on it falls on the family, but it falls also on the older people. So like a spouse caring for the wife, or or a person, older people caring for their sibling even, or caring for their family member. So it is definitely. And finances, you talked about what specifically? Somebody talked about finances on the family. So how would that affect the finances on the family? Yes, Palestine.
It will be a burden on the family in terms of finances. Yani, it will be more economical burden where the family won't be able like to fulfill their duties in terms of living conditions and to care for the people with dementia in terms of medications, appointment, doctors' checkups, and so on.
Okay, great. So it's an issue of also how much we pay for this. And of course, and within family, we can expect like more maybe than one with dementia. What about the health system? So what would be the burden, or what would be the impact on the healthcare system, knowing about at least you've been, of course, exposed to the healthcare system. So what will happen to the healthcare system with the increase in dementia? Rafah?
So hospitals, yes, hospitals and clinics, of course, will be overcrowded. And we know Lebanon doesn't have enough specialists in dementia care. So training more doctors and nurses will be a need, and the system will need new services, new centers specialized in dementia for long-term care. And
Okay. Yes. So when we talk about capacity, can you be more specific? What kind of capacity you are referring to?
so,
Capacity of what?
the capacity of specialists, the human resources first, specialists like psychiatrists,
Okay,
neurologists.
so resources. So you
Yes.
need more resources.
Yes.
I've also heard other people and other breakout room talking about it. But what would be also the capacity of what? So
Maybe
yes, Noor. Yes,
maybe
Noor.
the bed capacity, since they will be sitting more in the hospital, so they will be acquiring nosocomial infections, which will increase the length of stay and the cost as
Okay.
well.
Okay, so we're talking about dementia patient. Most of the care of dementia patient happens either at home by informal caregivers, so the family cares for dementia. We have the social care, so I want to introduce this because there's the social care, so where we put, which are the institutionalized people with dementia. And actually now we have only 1% of all our older adults who are hospitalized. So let's say we have, then let's say 12% of our population are 65 and above. We have 1% of those who are in institution, and 60% of those in institution have some form of dementia. Most of the time it is Alzheimer. So we think about capacity, maybe capacity of nursing homes or institution that care for people who are institutionalized, and we don't have enough, right? So when we think about beds, it's not about only hospital bed, it's about beds and nursing care and long-term institution that, because if we don't have caregivers and we don't have assisted living, so the only place where these people are taken care of are institutions. We don't have enough of those institutions. So if there is no increase or at least a thought of expanding those social institutions which are under the Ministry of Social Affairs, I think we will have also an issue of taking care of these people, especially those who don't have family caregivers. Okay, so that's very important. So resources, capacity, and some of you talked about cadre of medical, that we will need maybe more geriatrician, we'll need more geriatric nurses. And Rula, would you like to come in here to talk about training?
Yes, so it's important for the students and for the residents to have training specifically for geriatric care, because it has specific aspects that are different than the regular care of normal adults. Yeah, so it's a whole spectrum, and it's multidisciplinary. So it's not just one physician usually, because they require a neurologist and a cardiologist,
Yes.
and it's all together. So this whole
Yes.
interdisciplinary care should be provided as
Yes.
well.
And if we think about the current system that has already some flaws and
Yes.
some flaws, some gap in training in geriatric care, and I think those of you who are medical doctor, you know that we don't have yet good geriatric care. We don't have a lot of nurses who are trained as geriatric nursing. So I think there will be a lot of burden on the system. And if the system does not provide training for those people, not only geriatric, but geriatric and associated illnesses, I mean, the quality of care will not be as good, and the outcome of the care would not be as good. So I think there would be a burden, there would be a pressure on the system that could be only relieved if we have some training. And economically, Abdulrahman, would you like to talk about economical and then Noor maybe? So both of you. So let's
Yes.
start with Abdulrahman and maybe Noor. Musulmani can then follow.
First, I think that when people would be diagnosed with dementia, this was this would certainly lead to less productivity, and which leads to the يعني, less workforce in general in the economy. So this will definitely affect the economical cycle in Lebanon يعني.
Great.
And
So that's the point. Productivity of the person, but the person, remember that this person usually are 65 and above, unless we have maybe a change of dementia and we have more younger people having dementia. But these are people who are usually on the retirement age. So the productivity usually is its effect is more on from the caregiver side, because usually caregiver until now are people who are in their 40 or 50s, female, who stop working because they need that person needs 24/7 care. And even if not the caregiver is providing the care, we need paid caregiver. And this is again, it's a burden on the family. So going back to the finances on the family. Noor, what else? What other effect on economy? And think broadly, not only within the family.
From my experience, I would like to highlight this point that the patient with dementia are always presented with other multiple comorbidities. So during my work in community pharmacist, their family members who are caring of them are always worried about dividing their medication in boxes. So they won't miss taking the recommended medication daily because they are not aware how many medication they should take during the day. So we always dispense medication boxes Monday, Tuesday, listing the days of the week.
They need to be, yes, of course, because people who have dementia are old people, and old people have dual challenges, though dementia, because they will also have other chronic conditions that they need to take care of, and not only their dementia thing. What happened economically at a higher level is also when we think about the Ministry of Public Health, because or the Ministry of Social Affairs, what would be it's the budget, how much budget would be allocated? Because if we think about dementia, there was a statement by a long time ago by the WHO director, WHO director, long time ago. She said at the time, Margaret Chan, she said that there will be a tsunami of dementia cases in the world. A tsunami. And when we talk about tsunami at the level of a country, it means that the country, with the governmental body that take care of these people, needs to increase its budget to support. It's like the Ministry of Public Health when it puts a budget for medication of chronic diseases or medication for cancer or for prevention, right? So the Ministry of Social Affairs as well needs to have a budget. So what happens economically is that we have to think about a state budget that is at least planned or that is aligned with this big crisis that will come. Okay, so eventually the learning objective of this presentation is you need to understand very well what's dementia, what's its diagnostic criteria. We won't spend too much time on it, but these are important because the key focus always is on measurement, how to measure dementia. How to analyze it as a major public health issue. And we've done some of it right now because we talked about burden, we talked about economy, we talked about the healthcare system. So all these are characterize dementia as a major public health issue, right? And what else? When we talk about dementia as a major public health issue, what would come to your mind quickly?
Prevention as epidemiologist.
Before prevention, and it is a major public health issue. I need to start working on it. I need to do something about it. When do I decide
need
also
to
this?
know, maybe the burden, how much, where.
Yes, burden. Yes, exactly. This is the language that you need to talk about, prevalence. So we analyze dementia. It's a major public health issue because it is a high prevalence. It's the prevalence because based on the prevalence, we allocate resources. And then all what we have said before, we did the scenario if it increases, but we know now that we do have a burden right now, and it does affect the caregiver, it does affect the family, it does affect productivity, it does affect their mental well-being, it affects the finances, and it affects the healthcare system. So as we're talking about dementia as a major public health issue, of course, second, as epidemiologists, we need to identify and think about what are the major risk factors, because then the focus would be on prevention, right? So we want to see what are the factors that we as public health people and epidemiologists we can intervene with, so we can modify the disease and reduce its incidence, and reduce its, not maybe its incidence, but as well as its complications. So we can either reduce the development, or we can reduce its complication. And of course, we'd like to know what's going on, and that's particularly what I have put in my presentation that I will share directly after this one on the MENA region. What are the current status of dementia in terms of research, in terms of program, in terms of the interest in dementia in the MENA region. And at the same time, I added them up, and we'd like to know you to identify some available interventions that are done, which one are working or not. And very importantly, because the key focus in EPI is measurement, because the key focus is to come up with numbers and try to know the burden, we have to address some of the challenges to dementia research, and also think about what are methodological challenges when we deal with the dementia cases. So quickly, there are a lot of myth and misconception about dementia, and even if I give you a true and false questions, of course, many of you have a background, you have a health background, and I'm sure that I believe that many of you would know the answer. But in general, there are misconceptions among the population, and that actually makes the situation worse, because it delays a diagnosis. So it's a major barrier to diagnosis and to public health policy, to effective public health policy. It's not an inevitable decline. It's not like something that everyone would have because it's aging. We have to recognize that it's a pathological condition that affects many domains of the brain. And that does not mean that if our parents have it, we will have it, but we'll have a high chance of having it, and that it cannot be prevented. No, we have some modifiable risk factor that might delay the onset. And I think it's one of the major, not misconception, but people mix dementia and Alzheimer. But just to know that, yes, Alzheimer is dementia. It's only one type of dementia, which constitutes 60 or 70% of the dementia is of the Alzheimer type. So it's always, as we are doing research, epidemiological research, is to know exactly what is a case, right? So we have several classifications. The DSM-5 classification now is called, they classify dementia as a major neurocognitive disorder. ICD-10, also the broad category is neurocognitive disorder. And so it is an umbrella often used in public health. So, but in the clinical setting, it's a neurocognitive disorder. Most important, it's like depression. So we have to have significant cognitive decline. And when we say cognitive decline, it means that the people are performing poorer than they used to do. So there is a baseline level of performance. And as we move in time, if people change their level of performance significantly, we'll see what is the significantly, meaning it interfering with their social life, with their work. This is significant. So it has to have, so therefore very important from a previous level of performance. So there is a decline. It's not related to any other psychiatric problem, like specifically depression or delirium or any other. That's why doctors rule out. There's always like a list of mental illnesses that neurologists try to rule out before they define dementia. And it's a progressive course, a progressive, meaning that it's a gradual decline. So if things happen abruptly, for instance, from one day to the other, somebody started forgetting or behaving differently, this acute change, mostly it's something due to like TIA, transit ischemic attack, but this is not dementia. It has to be gradual decline and decline in one of the cognitive domain. The cognitive domain are the complex attention, executive function, learning new things, and of course memory is very important, specifically in Alzheimer. Language, so they lose their language, perceptual motor function, and social cognition. So also they lose their social know-how or their social savoir-vivre or whatever I can call it. So this is very important. Yes.
They are not oriented to the setting.
Sorry. Yes, there are, of course, orientation, definitely. It's a complex, this is under complex attention, so they would not be able, of course, they will lack orientation to space, time, and person. Very important, by the way, and we will be addressing this. So orientation to place is very important. That's why dementia people need to remain in familiar places. So moving somebody from one place to the other, to a place where that's unfamiliar to them might really affect them and would result in a severe decline of their status. But again, very important when you talk about dementia, are you talking about all forms of dementia? Are you talking about Alzheimer? And then how do you define dementia? Need to be very clear, okay, with the order. So, and then these are the subtypes. So it's important, as I said, because some of the dementia, like Lewy body, frontotemporal, or mixed dementia, are very different from the first two that are the most common. So the most common are the Alzheimer, which result from accumulation of beta amyloid plaque, and this is why we do a test of beta amyloid 40 and 42, and we look at the ratio to see if people have this ratio of beta amyloid. And then there is also a deposit of a certain protein that when it is deposited there with the beta amyloid, it becomes pathologic, and it will actually, it is on the neuron, and it prevents this connection between the neuron. This is said very, of course, I apologize from the medical people here, so I'm trying to talk about it in very simple term and not using those very medical oriented terms. But the most important is Alzheimer. It's like accumulation of beta amyloid and tau. The vascular is related. We call it here that so there is either like bleeding in the brain. So it's related to a vessel disease, either post-stroke or small vessel disease. But at this point in time, there's a lot of reading that talks about that irrespective, the dementia is ultimately, it results in accumulation of beta amyloid. So it's not only the Alzheimer disease type, but any type of dementia. The Lewy body, again, there is abnormal protein deposit in the brain cell. Frontotemporal comes to Lewy body and frontotemporal. They occur to people who are younger than the first two type. It's progressive and it does affect the behavior and personality and language. And the last two usually are life expectancy is much shorter than Alzheimer and vascular dementia. I mean, they don't live much long after they are being diagnosed. And we have the mixed dementia, which is multiple pathology that's not that's usually underdiagnosed. And again, these are the numbers. So how is dementia diagnosed? We don't have a one single test. Now you see in some of the literature saying now we have a test for dementia. That's not true. You can go have your blood tested for beta amyloid. You can have your blood tested for p-tau, p-tau 181 or p-tau 217. There is also 4 or 5 biomarkers. But having pathology in the brain does not always translate into people showing those declines in cognitive. So we call it like a cognitive, we call it reserve, cognitive reserve. So some people, other than the cognitive reserve, that's due to education. So there is like cognitive resilience. Sorry, I apologize. It's called cognitive resilience. So some people do exhibit either in MRIs or some brain imaging other than MRI or in a biomarker. They do exhibit some changes, pathological changes, but yet these pathological changes, they don't translate into actual symptoms of dementia. And this is where we talk about resilience. So therefore, dementia is not only the testing, not the imaging, not the blood biomarker, because I think I have missed to put blood biomarker with the imaging down, that we have the blood biomarkers. So we have a clinical history, we have a cognitive testing, so batteries of tests that where we test the memory of people, if they are able to have orientation to time, whether they have verbal fluency. So like now we have like maybe 19 tests for these. But most important, or not most important, and an important element in the diagnosis of dementia is having a component where an informant or a next of kin or somebody who knows the person who is being tested, who knows him him or her very well. So that person can give some information about the the change in behavior for the past few years. So usually an informant is asked, for instance, did this person change his behavior or compared to the last 10 years? Did this person, forgetting stuff compared to the last 2 years? So there is like a list. So we include all this information with the cognitive testing, with the clinical history, some neurological exams as well, and the imaging as well with the blood biomarkers. So these also, it's a multiple component assessment. So therefore, to decide what's the case, so there should be a cognitive decline, as I said, functional impairment, using standardized criteria, and we have to have valid assessment tools. All right. So, and this is where we can define a case. And the measurement, actually, the definition affects the prevalence. And what is the how are you measuring a case? So it would be very much different than a case in a neurology clinic where somebody would where neurologists have a MOCA. A MOCA is I don't know what MOCA stands for. Maybe Rani would know or Rula would know. And then it's a screening test, and they decide whether somebody has dementia or not. Whether a case for the prevalence is, especially for research, is much more rigorous. Where I said it needs to have like an algorithm and collecting data from different sources, making sure that the tests that we're using are not only valid, but valid for the specific cultural context, and then doing working on the specificity of the case. So for the screening is fine. We can be more or less not very specific or sensitive because we only screen. But when it comes to clinical and research, I think we need to be more careful about what is a case of dementia. So therefore, based on this, when we talk about measurements, so just to tell you that the research now, we have, and usually most diagnoses, so it's either a two-stage design where you start with the screening phase and then you collect more rigorous information. So you do like mini mental state examination, few questions, but then you confirm with clinical diagnoses. Okay, but the problem is when we do a two-stage design is many people, they don't come back for the rigorous exam, and they don't want to, because the cognitive battery, you might need like half an hour to 1 hour to complete all these cognitive battery. while in a clinic, a neurologist would spend like few minutes administering 20 questions, while it's different for a clinical confirmation with so many tools, especially if we're talking about research. While there exists now some one-stage design, one-stage assessment, where they integrate a lot of protocols. One of them is now called 1066. So they do cognitive testing, informant interview, and clinical exam together. It definitely is more cost effective because you don't have to call back the person. You do it in one time, even in research. So we go once. We don't screen and then take a sample of positive and a sample of negative to do a longer assessment, but we take everyone we select, and we administer all kind of tests because it is more cost efficient. It's more burden on the person at one point in time, but at least the person doesn't have to come back for a longer testing, and definitely it reduces attrition. So these are the type of screening and diagnostic tools, and so these are, I don't know how. So do you know why we screen? So why do we screen? What's the value of screening?
Screening is mainly a very sensitive tool, not have a high specificity.
Why do we
So in
screen?
case,
But what's the value of screening?
because as we know, dementia is a progressive disease. So early detection might increase the quality of life of a person having dementia.
Okay, thank you. This is your point of view. Let's have a general discussion. So Janine, why do we screen? What's the value of screening in public health?
I think for the prevalence.
Screening. Why do we screen in public health? Why do we screen for breast cancer? Yes, please.
I
To
think
know
so
the
we can know
Sorry,
where to allocate.
one at a time. Sorry.
I think so we know where to allocate our resources يعني more properly يعني we can't like go and just apply our di our diagnostic tools directly without knowing.
No, so this is not the answer, Abdul Rahman. So can we have Rani? Why do we screen? Rani, are you with us? Okay, so
Can we answer?
yes, Rula, please.
Yes,
Who's
it's
it?
for early
Rula?
for early detection mainly, so that we can manage early before complications happen.
Excellent. So we want, because we will have a better prognosis, right? So let's say if we do breast cancer, so we want to screen before symptoms appear, right? So we can at least reduce, so capture the dementia or whatever condition early, right? So we can intervene, right?
Yes.
Yes. Are you all with me? Why do we screen as public health? Why do we screen?
Yes. Yes.
Okay. Okay, diagnose. Okay, so you're doing research. You want to know how many have dementia. A patient goes to the neurologist. He or she have noticed changes, so she goes to the neurologist, and the neurologist need to diagnose. This is different. We're saying, why do we screen? So if we want to screen, we have to think about, so to screen or not to screen dementia. What would you say? So I'm going to leave you to think about screen or not to screen, and we'll have a debate. So room 124, I want you to give me some reason why we want to screen for dementia. And 567, your position will be against, and I'd like to have this discussion. Okay, thinking about what is screening, what you know from screening in general. And again, screening is to identify people who could have maybe early dementia, to do something about it, right? Or to not to do it. At least this is it at early stages, right? So let's see. So room 1 to 4, I'm going to randomly allocate you into breakout room. 1 to 4 are with screening, and 5, 6, 7 are against screening, and we will debate. Okay, give me a second. Okay, and then breakout rooms. And I need, we already have the rooms. I have 6. How many rooms? 7. Noor, you are alone in the room. So I will assign you to another. So let's say we have 6 rooms. So 1 to 3 is 4, and 4, 5, 6 is against. Okay. But allow me first to move into room 2. Okay, I'll remove room 5. Yes. So again, 1, 2, نور وحدة is 2, 6, delete, yes. And, so okay, on the screen we have 1, 2, 6, and 7. Where are the remaining 1? Did people leave? No. Wrong. Treatment, these ones. Okay, should I assign to add rooms? Broadcast. So, but just that I wanna. So, room 2, it's Noor, Rima, and Sadil. You are 4 screening. Room 6, Noor, Rafah, and Rani is 4 screening. So 2, 6 is 4 screening. And 7 and 1. So 1 and 7 are against. I don't know if we have still people who are not assigned. These ones. Okay, so again, sorry for the confusion. I don't know why some of the rooms disappeared. So again, and I couldn't restore 1, 2, 3. So again, I will repeat maybe 1, 2 are 4, 6 against, 7 against, and 8 against. So, okay, 1, 2, 4, but then 6, 7, 8 against. All right, and 3 minutes.
I have them as documents or have the email.
Okay, so I'll be calling you to the main session, and I'll close the room, so you'll have like 60 seconds before all rooms are closed. Okay, we're all back. Okay, so let's start, and let's have quickly, for those who were with a screening, group one, quickly, what are your arguments for with screening? And let it be please brief and quick.
Okay, so if you want to go back to the beginning of our discussion when we were saying the effects of on the family, on this healthcare system, and financially. So if we screen early, maybe we can manage to allocate resources in a better way because we know the prevalence of what we have. So we can allocate the resources better. We can educate the the caregivers on what to expect, maybe teach them how to cope better so that they're not just directly bombarded with the news. So if we progressively work on it, it would be better. And as well, we were discussing the issue of prevention, and managing complications early on.
Okay, thank you, Rola. So the second group, and then other groups who, because I went into another room and they said we are more actually convinced of screening. So anyway, so let's hear from the second group on what are the arguments for screening. So we're talking about like preparedness, yani, as I put it, anticipated preparedness, or maybe if the dementia is screened early, what can maybe do something to prevent maybe complications or whatever through some activities that could be. So group, yes, second group.
Yes, doctor. So in our group, we discussed that screening would help us to early detect small unrecognizable changes, and that is due to the progressive nature of the disease itself. So sometimes the patient might or the person might exhibit small changes that are unrecognizable, but in fact they are signs of early disease.
But
so
why would you screen? Why would you screen?
Yeah, so we would screen to enhance the prognosis and to slow the progress due to certain interventions, and that would lead to increased quality of life for the patient and the caregivers.
Okay. All right. Thank you, Rima. Any other argument for screening? Any other argument? So the group where we had Rani and I don't recall who else. I mean, maybe Farah. You said that you are more convinced with the screening. So why do you want to screen? And what if you are to screen? What would be the minimum age that you would choose, for instance? So I don't see anyone strong argument for screening. So what about, okay, so let's go to the group that is against screening. So why against screening?
We said that there could be like some false positives or false negatives. That's the first issue, because I think screening is not like 100% diagnosis, so like confirm. So that could there's an ethical issue with that.
Yes. So what would happen if you say someone has dementia and it's a false positive?
Yeah, first the patient could become like overwhelmed, like what am I gonna do? Things like that. And also you might start like wasting resources on someone that doesn't necessarily need them if it's a false positive. And also we talked about the absence of like proper treatment, especially if we're talking in Lebanon. So yes, the patient might be like truly they could have the dementia, but there's no like they financially can't afford proper treatment. So then what was the point of this early screening?
Okay.
If you
so
can't
we don't,
give
just
like care.
to say, yes, we don't have treatment yet. So we have some medication. And again, please help me, those who are medical, the MD people, that can slow down the progression or stabilize the situation so people can live longer, be socially present, can manage their life better when they are on the memantine and the anticholinergic drug. So like Aricept and Aricept for anticholinergic and memantine, like Ebixa for memantine. So this can actually slow down the progression, but we don't have treatment yet. And the only treatment that now Nodicum, whatever, it's very complicated, the name is, it's $25,000. So not available to everyone. So the issue of the fairness also and people having access to care can be also problematic. So not all people can have access to care if so screening, when you say screening, and we're talking about mass screening or screening all people who come to primary care center for for dementia. So what should I do when I know? So what can they take the medication? Can they afford taking the medication? And the one that's very expensive, it's not available here. And then it should be really detected at a very early age, so people can actually benefit from it. And I don't know if it doesn't, it's irreversible. So the changes and the pathological changes are irreversible. But again, as I said, it might maybe delay the full full onset of the symptom, or it can slow the progression of the disease. So we talked about the false positive. We talked about the not medication, and what's important also for the person. And you tell me that you have your teeth, you have your potential. You have dementia. You have to go and have a full clinical exam, right? So we have also to have a full clinical exam that might not be there. And what else from the perspective of the patient, of the person? It
Maybe
might
doctors,
really,
yes,
yes,
maybe
Rima.
they will be stigmatized about it, like, and labeled.
Stigma, 100%. What else? Stigma. Can you think about other people might be afraid to lose their
Yes.
job? If you report that people might have, so people might be afraid to lose their job psychologically, and thinking that they might, like they put it, that they might lose their mind. They will not they will be cognitively impaired. So there are a lot of issues related to knowing, and sometimes it depends. And I know that I've been at the Alzheimer International Association conference, where we have advocate for dementia. We have patients coming in and talking in these big conferences, but these are from different educational level, and when they realize, and I think it depends on how people, the society, embrace this disease, how much they talk about it. We isolate, so even the person might be isolated from other people. We isolate, and not all the people isolate them. So there they can talk about it. They put plans in place. They say that I will stop maybe driving. My wife I will stop doing my expenses, etc. So it will be difficult for those with the low literacy level, and those who don't have enough support. So I think it's pretty difficult to have the screening and have like anyone who comes, you screen for dementia. I don't know what you, as Dr. Rani, I don't know, Rani, if is with us, maybe not very interested in the topic, or he left already. Is Rani here, Hassan?
Yes.
Rani, I'm not hearing your voice at all. I don't know, maybe
Yes.
you're not very much interested in the topic, so I'd like to hear your point of view on screening. So would you advocate for screening and primary care? So let's say people coming to the AUB clinics, not clinics, infirmary. So people coming to the infirmary, would you advocate? So would you push? Would you recommend screening of people who are 60 and above to be screened for dementia when they come? So we screen for hypertension, right? We screen for
Yeah,
hypertension, for diabetes, for cholesterol. Are you in favor of screening for dementia?
I would say yes, but depends on the tool we're using. We're also like have to be
So when you
cautious.
say tool, mean if a tool is not specific and sensitive, right?
Yes.
Okay, and specifically you want to have specificity, right? So you don't want to have false positive, right?
Yes, also like we aim first for the tool to have a high sensitivity
Yeah.
to rule out dementia first. And then
what's more important?
first sensitivity, we want to rule
Okay.
out the condition. If it was
Okay.
positive, we move to a specific tool.
Okay. So you want it to be sensitive, okay?
Yes,
So if it's
first,
not sensitive, it means that you have false what? False negative.
false negative, yes.
Okay, so how much is important? False negative or false positive in the case of dementia? Right. So if you are screening for cancer, right? You
Yes.
have to have, I mean, you don't want to miss the cancer, right?
Mm-hmm.
But if you're screening for dementia, so you don't want to miss a dementia person, or you don't want to label somebody dementia if this person is not doesn't have dementia. So what's more important? And again, we know screening, and we know when we think about screening that we don't want to miss anyone. So that's why
Mm-hmm.
we screen, and then we do the second level, right? So we want to
Yes.
have more people. We want to make sure that people are positive, given positive, right? So this is your sensitivity.
Yes.
Yeah. And if they are not, if what we had, it will be a false negative, right? Because the people
Mm-hmm.
are positive, but I'm saying you're okay, go home. But you
Mm-hmm.
don't want to send anyone home and positive, right?
Yes.
Sure. It's like HIV, which is very important.
Mm-hmm.
But for dementia, I mean, I would think about it. Yani, it's not like I want sensitive screening, but I think as important, if not more, is to have a high specificity. Sorry, high specificity, right?
Mm.
Okay, so but sorry, I'm arguing, and again, this is
No.
my point of view because of all the consequences of labeling somebody with dementia and not making sure, not being able to maybe even having a definite diagnosis of dementia, especially at the very early time. Remember that you are trying to pick up the disease at its early stages, right?
Mm-hmm.
And maybe a
Yes.
change, a pathological change, or a change in memory might not lead maybe to full-fledged dementia. Maybe yes, maybe no. It might
Mm-hmm.
remain, let's say, maybe mild cognitive impairment for a long period of time. So do you want to
Mm-hmm.
label somebody with dementia?
Mm.
Did you get me? So this I think this dilemma is important given the ethical issues, the stigma, the fear, the psychological stress if somebody and the readiness, and if the system is not ready, and I think this is very important. If the system is not ready to accommodate, how can we go into a screening? I would understand maybe people coming for a checkup. Okay, let me check up. We do that at the geriatric care, right? They check out their people cognitive, but they don't do it as a screening for everyone, right? So when we talk about screening, I'm saying anyone who comes to the primary care, the nurse would screen for all this in addition to MMSE. So I think this is debatable. Okay, so
Also,
what I would, yes, please go
another
ahead.
important point is that we should have a specific tool in order not to overdiagnose dementia.
Yes, yes, 100%, 100%. Thank you. Anyone else has like a final points on this? Anyone that I haven't seen or did not address? Tasneem, Busola, if do you have anything to add? Sorry, I don't see you all the time, everyone on the screen. You keep disappearing and coming back. So Busola, Tasneem, Razan. So
Okay,
we're good?
so
Yes,
for
yes,
the stigma
Busola.
part, we said
Yes,
something in my breakout room on how that it can affect their employment and
yes,
social relationships if they, because we are against screening, so in my
yeah,
breakout room, so if they already have like a record of possible Alzheimer, so it could
yeah,
affect people might not want to employ them, or even maybe their insurance. They could be like, oh, maybe they have like a potential of having a chronic disease, even if it might
yes.
not necessarily be true or not. So
Yes,
that's one
and
thing.
yes, thank you. And important now that it's not, one has to go to make sure that those people that we screen, we are able to directly or call them back for a longer assessment, a more thorough assessment, right? It's not like only screening and then, wow, you have a probability of having dementia, but as well as having, for those positive, is to have this full battery that we now we have, definitely. But again, we don't have, for instance, the biomarkers. We don't have any lab in Lebanon that test for these biomarkers, by the way. Neurologists, they do take MRIs, and then they look at shrinkage of the brain, the volume of the white or gray matter, but there's nothing like 100% that says, yes, this person has dementia in the brain if I see a brain image. So it's a lot of, that's why the challenge in dementia measurement is that it cannot, it's a multi-test. It's we don't have it, and we don't have all the validated tools, and it requires information from different sources to affirm and to verify the diagnosis, right? Okay, I will be sharing with you an article. Please do read it. Is to screen or not to screen in primary care. I wanted to share it with you actually before, but I thought that since you have the Lancet, it will be too much to read. But anyway, you can read the to screen or not to screen, very short article, very nicely written, that gives argument for both. And I think we covered all. If we haven't covered all, again, it's good that you would at least read what are the things that we haven't covered and to screen or not to screen. Can you please remind me what time is the class?
It's at 4, Doctor.
It's at 4.
Until 4. Thank you. Okay. Thank you. Okay. All right. So we talked about this. Of course, okay, sorry. Okay. So therefore, other challenges and measurement of dementia that are actually important when we think about carrying epidemiological research are again issues of illiteracy, because we have a lot of tests, for instance, that require people's knowledge of language or drawing or writing a sentence or something. So one has to think about the right test for the right type of people. And now we have some tests that do not require literacy of the participant for them to fill it in. And this is very important. So sometimes because they don't have a formal education, they are not able to perform well in the test, and not because of their dementia. So that's why when we approach and when we do a research, you have to understand well your population literacy level to know which kind of test you want to administer. So any test that requires drawing, writing, subtracting a number, like start with 100 and then subtract 7, these are things that requires a minimum level of literacy. Informant reliability, as I said, that when we want to ascertain dementia, we have to have a component, an element of the diagnosis comes from an informant. And we have to make sure that that informant knows very well the participant, the person who's being diagnosed or being studied. And so therefore, because the ones, they need to know them for a period of time, have lived with them for a period of time, and at least to know that these members also, they report this, they don't underreport the symptom, because they think that, yes, this is normal aging, why should I report that person is forgetting or something. There's always, when we measure, generally, when we talk about older adult research, there's always an age misreporting, especially when we talk about prevalence rate. So are we talking 59, 60, 64, 65? And we try always to get a documentation of people's age. This is irrespective of dementia, but usually when we are talking about older cohort, the length of the questionnaire is important when we do dementia study, because the battery tests usually are long. So in order to attend to this, what we did in a most recent study called Lebanon Study on Health and Aging, we wanted to make sure that the participant who has to answer a battery of tests that goes from sociodemographic, including occupation, mental health, depression, anxiety, life event, disability, cognitive, and so many other modules. So we wanted to make sure that the cognitive, because we focused on dementia. So what we did is in the questionnaire, we put it at the beginning. So at least to attend to attrition in case attrition happen. And in case people becomes too tired to perform well at the end or to answer well at the end. So what we did is we put them at the beginning. Sometimes you think about even the length of the questionnaire. So you compromise. You say you sacrifice some of the module in order to make sure that whatever you are asking is not very long, so the participant, especially those who have mild dementia, but they can answer you. Just mind you that a participant in your research who have mild to moderate dementia can answer your question. Somebody with severe dementia who have lived with Alzheimer for a while will not be able to answer any of your question. And these people usually are not part of the research that we do because they are not capable of giving you consenting. So therefore, in any EPI study, which addresses the cognitive health of older adult, what we can capture are normal cognition and decline, but decline to the level that people can answer. When it is severe decline, actually these people cannot be part of your at least baseline data. Maybe they will become later, they will become full-fledged with Alzheimer's disease, but nevertheless, at the beginning, they might have mild to moderate, and these people can understand the consent form, and therefore they can answer you. And not to mention that we might have missing data as any other. So the ethical issue, the informed consent from somebody who has dementia, that's why we do something called decision-making capacity, so that we make sure that they understand our consent. We take into consideration the interview fatigue, very important, the confidentiality of the people, and definitely we have to think of, since we have sometimes proxy respondent if they are fatigued, or we have informant, we have to make sure that data are reliable. Okay, so dementia is a public health problem. Population aging, we have high level of aging. It's a major cause of disability because people are very much dependent on others. And I can tell you that people who have the full-fledged dementia, 100% of them will be dependent on others. Maybe at the beginning they are not, especially when we are on a scale, on a continuum, the MCI, so mild cognitive impairment, people might be still able to live independently to some extent, but once there is a diagnosis of dementia, people are unable to live on their own and they need care. So high caregiver burden, it's a public health issue and as a major economic cost. So I want you to think about, and just I will leave you and then you can give me, we don't have to do pairing in small groups. So beyond aging, so let me tell you, age is the strongest risk factor for dementia. Beyond 85, 1 in 3 person would have dementia. So you have to know this particular number. So the prevalence of dementia in Lebanon is 7.4. The standardized is 9 based on the Western European country. It's 9 point something. However, if you look at the prevalence by age, it's exponentially increased. And after age 85, 1/3 of people who's above age 65 will have dementia. So definitely age is a strong factor, but it is not the only factor. And it's not age that's the only driver for rising dementia rates, especially in low-income countries. So can you think, like, for 2 minutes, beyond aging, what would be a major drivers behind rising dementia rate in low-income country or high dementia rate in low-income countries? So we know that low-income countries are witnessing demographic transition, increased number of population, and in the MENA region and in low middle-income country, we will have the largest absolute number of people greater than 65 globally, right? So beyond aging, what could be other major driver? From the, I don't know if you have seen the handout, you should have an idea about what could be the major drivers. So 2 minutes. And I want to get to that reflection now, another slide, and then we'll stop. Sorry, I was talking and I was muted. So can I have some ideas from you? So the people
yeah,
who I haven't
oh,
heard
sorry.
from Razan. So let me say, Razan, I haven't heard your voice. but the Razan وتصنيم who else? عبد حكي رفح جنين. Okay, so let's Razan وجنين sorry Razan ومين قلنا؟ تصنيم and Sadil. يلا.
Okay.
Who would like to start?
Okay,
Yes,
we
Fat.
know that in low middle income countries they are suffering from high prevalence of NCDs such as hypertension, diabetes, and cardiovascular disease. And we all know that those conditions affect the blood vessels, including the brain, which will increase the risk of dementia.
Excellent. Thank
Vascular
you.
dementia.
Thank
Yes.
you. Not only could be vascular, but anyway, because we think at one point in time that everything has maybe the same risk factor. It's not only about, I mean, even diabetes. Now we talk about diabetes as the third type of dementia. And it's not really about only diabetes affecting the vessels and the vascular health, but much beyond this. And it is related also to this beta amyloid and beta. Thank you so much. So it's related to the NCD, which are major risk factor. Hypertension, diabetes are two major risk factor for and other heart disease. So healthy brain, healthy heart, healthy brain. So yes, and we know that how prevalent, right? You know that you will be getting the NCDs, epi, you know, it's around 50% above the age of 65 who have hypertension. The problem is not only just having hypertension, but having also uncontrolled hypertension. So not taking your medication and not having controlled hypertension, similar for diabetes. Okay, great. That's great. Razan? Any other thoughts
Yes,
on what could be major driver in low and middle income country? And that's why, if I may, entre parenthèses, between brackets, in the high income country, they are witnessing a decrease in the incidence. And they are, the thought is that this decreased incidence because of the control of some of the NCDs. So we have reduced incidence of dementia. Yes, yes, go ahead, Reza.
So there are social factors that are more prominent in people who live in low-income countries, such as isolation, depression, and stress. So this can increase the risk of dementia in those people.
Excellent. Social isolation, people leaving, not having that's excellent. Any last thought on this?
Yes, we also have limited access to healthcare. So, in many low income settings, there is limited access to preventive healthcare and early diagnosis and also treatment for the chronic diseases. So, the poor management for these conditions would increase the brain damage and thus the dementia risk.
Excellent, excellent. So what about protective factor? So we haven't gone through them, and I know that you will go through them. So I don't want you just to memorize. So you will see my slide. So there are risk factor, but there are protective factor too. So one of the protective factor is social engagement, is access to maybe social activities, social stimulation. So a lot of low-income countries, specifically, we're talking about low-income countries. It means that we have many people who don't have access to education, to social activity, to this engagement. So also this could be so we're talking about. Or another also protective factor is food, specific kind of food. مثلا avocado, low, I forgot what are the food. Yes,
whole nuts.
Whole nuts. Okay.
Yes,
thank you. So there are thank you. So there are particular type of diet where we have that could protect also against dementia. So this being said, these are important. And of course, this is important. It's not now. It's not at 65 that people should be exposed or not exposed to this. Very, very important before. Oops. Okay, now we still have a few minutes. So before I close, it's very important if please you look at the Lancet Commission and specifically look at the life course approach, because a lot of studies have already, and this is the Lancet Commission, have identified the risk factor and at which level these risk factors are important. So we have the non-modifiable, which are when people at birth, so the age, people a gene which is allele ApoE4. So this is something that we cannot modify, and this is people are born with this allele. So this is non-modifiable. So what's modifiable when people are young are what? So literacy is a risk factor because it does not provide the cognitive reserve. So starting with improving literacy at early life is important, right? And there are other things when people are young that needs to be modified in order to reduce dementia later on. At midlife, the one that you talked about, the hypertension, all these cardiovascular risk factors are very important. So what would be protective factor at early life that could be promoted to reduce all these NCDs?
Physical activity, doctor.
Excellent. Physical activity. What else?
Diet.
Diet, so to reduce obesity. Yes,
Sleeping.
excellent. Sorry?
Sleeping schedule.
Very important. Sleeping. She said sleeping.
What's sleeping mean?
Sleeping.
Sleeping. Sorry, I didn't get the sleeping. Yes, sleeping.
Yes.
Hearing, sleeping. So we have so many things. Very important at the older age group are social engagement. Social isolation is a major risk factor. I've talked to a neurologist at AUBMC who told me that after COVID-19, he used to see people who have MCI or even no symptoms or some symptoms of dementia who really deteriorated after being isolated from their kids due to COVID. So social isolation, that's why a big thing is to keep the person who's the dementia not to be ashamed, not to isolate. So that's why reducing the stigma makes it more easier for families to share this person, to keep this person in the society, being part of the society, engaging in whatever discussion or activity. So this is very important. So improving social engagement, reducing social isolation.
Yes, there is
Yes.
also smoking and
Hearing is important as well. When you lose your hearing, also people, they start losing the language. Yes, Rafah?
smoking and alcohol consumption. It's very important.
Excellent. Yes, yes, yes. At one point in time, by the way, let me tell you that smoking was thought as the only protective factor for dementia until an epidemiologist explained that as a survival bias, because those people who are heavy smokers specifically, they don't live long enough to get, yes.
And true,
Yes.
but
So
yeah.
yes, so that was then dismissed, and we are seeing more and more good studies with good association with, association between smoking and cognitive decline. War, stress, by the way, we have seen now, we are doing a study. So based on the cohort study that I've done recently, cross-sectional analysis, not cohort analysis, because we don't have yet wave 2. We've seen a strong association between older adult who's 60 and above, who have witnessed many years of war, and the more war event they have witnessed, the longer war event they witness, the more likely for them to have lower cognitive functioning. We're not saying yet, we haven't done yet the algorithm to diagnose somebody with dementia, but we've seen that their cognitive performance is lower. So those who experience war event, their cognitive performance is lower than those who experience less war event or not experiencing war event at all. And to conclude, I want you to think about something that's very contextual right now. So how might conflict, displacement, and all this and disruption made by our enemy be particularly harmful for people with dementia compared to cognitively healthy older adults? So imagine an 80-year-old man living with moderate dementia in south of Lebanon. Due to ongoing hostility and bombardment, he and his family, so I chose to be a he, actually AI chose to be a he. I asked AI to give me one scenario. He and his family, and I don't know why he chose a he, are forced to evacuate to a crowded shelter in another city. The environment is unfamiliar, noisy, and stressful. His daughter, who's his main giver, is also dealing with displacement and uncertainty. Anyone witnessed this? Anyone have experience in this?
Me personally, no, but
Yes.
like you said earlier, it's bad to move. It's not good for the person with dementia to move them to a new environment. And also, like, it's very noisy, it's very crowded, loud noises. I think they can be startled. And if the caregiver herself is stressed, she won't be able to like give adequate care to the person with dementia.
Yes, so it's really, we don't think about it. And when we go to to IDP center, we rush into giving medication, caring for the kids, for the pregnant, etc. Not much for older adults and much less or we don't think about them. And it's really, if we think about also the consequences of the war, for these 7%, at least I think it's much more now. I think recently the prevalence of dementia is like more than 10%. In rural, it's higher because of low literacy. And then people live longer. Yes. So again, the issue of the age. So I think it is a burden, and it's very difficult. We know that people go live sometimes 10 and 20 in one house, but it's very hard to manage somebody who has dementia, who leaves his place or her place and go to an unfamiliar place. So behavioral symptoms increase, agitation increases, the stress on the caregiving, and not to mention some people might not be able anymore to maybe access to care, access to the medication that are usually they control, because there are some medication that control some of the psychotic. Some of the people with dementia, they do some of them, not all. They exhibit psychotic behavior and inappropriate social behavior, and they sometimes experience delirium or so these are again, if they are not controlled, if people are not anymore to take their medication, and imagine people who fled the southern suburb, what would they take with them? So their kids, maybe the passport, some money. I don't know to what extent they think about all the medication of their grandparent or their parents who have so many problems. So I think I want to finish by this, is that it's true, I talk about dementia, it is a problem, it is a public health issue, everyone is getting old, and uh, yet, you will see that very few government are putting in place like some kind of a plan, a 5-year plan. We don't have much research on dementia. You will find I've done a search strategy. I only found 17 articles since 2015, I think, who talked about prevalence. Maybe only mine, I have only one study that I've done myself on incidence. So we don't have any incidence. We have lack of validated tools. We recently have one, but not everyone are using them. So I think the issue is that given this public health issue, more resources needs to be allocated, more knowledge, more information, more awareness session. And of course, yet we don't have many intervention, evidence-based intervention that work, but definitely we don't have one component intervention that works. So you cannot just improve literacy and things will change. So it's always, even the one that are done to adult or pre-dementia, they need to be multi-component, like addressing physical activity, improving cognitive research by improving people's cognitive stimulation, good diet, good social interaction. So multi-component intervention, they usually work, but we haven't seen yet this major decrease in incidence, but at least better quality of life and better health of the caregiver. So caregiver usually his burden is reduced by improving also the status of the dementia patient. I'll stop here. I hope that was like a comprehensive session. There's of course much more information to give, but again, I came with the assumption that you would have gone through my 11-minute video. You would have read the Lancet Commission, which is an excellent commission. I don't want to go through this. You would read it everywhere, that aging is high. The projection 300, as I said, there will be a growth in the number of dementia cases by 329%, as I told you. So these are the drivers, right? And then the non-modifiable disease, non-modifiable risk factor, we talked about them. Modified risk factor, you beautifully stated them, except the TBI, we didn't talk about traumatic brain injury. Depression is considered one risk factor, and usually when we diagnose dementia, we have to rule out depression, because sometimes depressed behave a little bit like the lack of concentration, and they don't do well on the cognitive test. So the life course approach. So this is the one where we have early life risk factor, midlife, and late life risk factor. These are the protective risk factors that, again, we talked about, and on the right side, there are the mechanism for action, how they work. I mean, how these physical activity, healthy diet work. They work through neuroplasticity, vascular health, and cognitive reserve. And this is the famous graph from Livingston, the Lancet. The Livingston is an amazing and excellent neurologist and a scholar in neurology research who has put in place that report, again showing how, and from this one actually, they have calculated the population attributable risk for the proportion attributable to this risk, proportion attributable risk for dementia. How much is the percent attributable to these dementia? How much is what's going on with me? So how much is attributable to these smoking, physical inactivity, etc. And what they concluded, like potentially modifiable is like 40%. So if we work on improving education, improving hearing, hypertension, and midlife, and improving all these later life modifiable diseases, we would be able to almost 35 to 40% we can prevent the incidence of depression. Okay, so these are reducing the burden and the research. And Damina, I leave you to listen to my talk. And what are the challenges? Low funding, no registries, lack of validated tool. I think these are important if you are interested in broadening your perspective about dementia, not only to Lebanon, but also to the region around us. And then I'm sorry, I don't have a chance to tell you about the research that I've done. You're welcome to ask any question, and you are welcome to take part in the research I'm doing called Al-Sahha. So we have data, you can analyze data if you are interested in issues related to older age and in terms of medical problems, social health in general, and cognitive health in particular. So that's we validated the tool, and this is the Al-Sahha study that we have, which is a cohort study where we have now 3,027. We have data on them. We have biomarker on them, HbA1c, vitamin D, cholesterol, and thyroid. But we have as well data on some of them on Alzheimer biomarkers. Okay, so that's it. Okay. Take-home messages. Growing crisis, definitions matter. There is a burden in the MENA region. Of course, prevention is a key for any disease, and we need more local research. Thank you.
Thank you very much, Doctor.
Thank you, Doctor. يعطيك العافية.
Addressing dementia.
Thank you all. Please stay safe. This is the last one on the mental health, so I hope you enjoyed it. I know that dementia and older age might not be very much on your agenda, young people, and maybe you are already exposed around you, your grandparents, your parents who are getting old, the society who's getting old. But please try to be safe. Your health, your safety, your health, and your mental health matters. So
I think
I don't know what to tell you.
numbers, that we've shown with you, we've shown with you now. It's very important to address it because we should look from a population health perspective. It's something which is very interpersonal. So if anyone of your family members has this disease, the whole family would be affected. So the whole population will be affected. This is from here the importance of addressing such issue. And with these numbers is very important, and it starts from research, of course.
Thank you, Rafah, and thank you all for attending. And yes.
Yes, I just want to ask, like dementia, it's sometimes integrated in genetics, right? Like if someone has dementia, that's the offspring has more chances of
Yes,
getting
family
that.
history. Yes,
Yeah.
of course, family history, similar to breast cancer, right? So if you have family history, it means that you are carrying that gene. So family history, yes, it is family history, does increase your chances, but doesn't mean that 100% you'll get it if you have that gene.
Thank you, Professor.
Because that's why I see a family with 4 people from the same mother and father who carry the same gene, but one person was more in her lifetime, was more active, employed, etc. I'm talking about one very close person. So that person did have dementia, but at a later stage. So sometimes addressing all these risk factors, they don't prevent dementia, but they postpone dementia, right? So you push, you defer it because you have so much cognitive reserve. So you are able to address any challenge, find your way because of all the cognitive reserves that you have accumulated during your life. So that's very important. Again, if you don't prevent it, you can defer it. You can defer it really to a later stage. That's why sometimes you hear, and he was okay. My father was 95 years old. He was okay, but the last year he began to lose his memory. He began behaving differently. It's just because that person actually might have this pathological changes, but he has this resilience because of the cognitive reserve. But at the end, people do die from something. So anyway. So take care, be careful, please stay connected with us to know your whereabouts if you move from place to place, if hopefully no major life event will happen to you. We pray that all these atrocity stop, hostilities, and see you around.
Thank you, Professor.
Thank you.
Thank you.
Bye.
Thank you,
Bye.
Doctor.
Bye.
Bye.
Bye.